Hello, everyone, and welcome to our 2024 series of the virtual Grand Rounds, Emerging Public Health Issues. I'm Dr. Kim Newell-Green, and I'll be the moderator, as usual, for today's session. And today we're addressing a very topical issue, our GLP-1 receptor agonists, the new panacea for weight loss. The management of obesity began to shift dramatically in 2014 when the first FDA approval of a GLP-1 receptor agonist for weight loss happened, liraglutide. But things really took off in 2021 with the approval of semaglutide under the brand name Wegovy. The weight loss with these medications is significant, but the side effects are as well. And it appears that patients are at a high risk of weight gain after discontinuation. Combined with their high cost and patchy insurance coverage, equitable access is also a concern. Today, I'm thrilled to have Dr. Carolyn Jasek join us to review the evidence and real-world data on this new class of medications for obesity. Before we begin, just a few housekeeping issues. Here are Dr. Jasek's disclosures, and I also want to say we really want to acknowledge CDPH as our partner in providing this relevant public health education for physicians in California. Next slide, please. Here is our agenda for today. Next slide, please. And just as a reminder, this series is accredited for CME credit, and you'll get a survey upon the completion of the webinar where you can attest to your attendance. So our usual presenter, Dr. Pan, will not join us today, and we're going to get right into our main topic. I would love to introduce Dr. Carolyn Jasek. Dr. Jasek is an adolescent medicine physician who's also board certified in clinical informatics, and she's the current chief medical officer of Omada Health, where she directs the clinical and research teams to create and test the next generation of chronic disease programming. In the past year, she's led the launch of expanding programs in diabetes, cardiovascular disease, and mental health. Prior to joining Omada, she worked at UCSF, the University of California, San Francisco, where she directed the implementation of the EPIC electronic health record, integrated digital health programming into clinical practice, and conducted clinical trials on health technology. She completed her undergraduate degree in public policy at Princeton University, her MD at University of Chicago, and her research training at UCSF. She continues her affiliation at UCSF, where she's an associate professor of pediatrics. So she hasn't done much with her time at all. And we're very grateful that she now has the time here to join us for this presentation. Take it away, Carol.
Well, thank you so much for having me here everybody. I'm just really thrilled to speak with my California physician colleagues about a topic that has taken up a lot of my time in the last year, and just really thrilled to be here to talk about GLP-1s. It's lately something I think about every single day, so I'm really looking forward to sharing more with you. So if we go to the next slide, just a couple additional disclosures. I do work at Omada Health. Omada Health is a virtual care provider. We are not a manufacturer of medications. We are a virtual healthcare provider in that way, much like a hospital, but as an employee there, I am a stockholder at Omada. I will not discuss any off-label use or investigational use of GLPs today. I can answer questions about those. Some of you may have those questions, especially me being a pediatrician. You may want to know about the under 12 set and GLPs. We can certainly have that conversation, but we'll be mostly just talking about approved use of these medications. So next slide, we can skip this because I think we've heard enough about me today. So our agenda, we're going to start with a GLP-1 overview. I thought a lot about what my California physician colleagues would want to get out of this, what would be the most useful thing, and what I would want to know if I was in your position. And it occurred to me that having a little bit of a deep dive on the GLP pipeline, just so that you're really up to speed with what's coming down the pike, so that you can kind of plan your time of when you need to become more aware of some of these new medications that are coming along, and then having a nice discussion of side effects and risks that are associated with the medications. This is something that comes up in my everyday, in my job, because we manage thousands and thousands of people who are pursuing weight loss. And so having a good finger on the pulse of side effects and what they mean for patients would be helpful. And then finally, having a really great discussion as we go into the Q&A on treatment barriers, which is the hot topic: who can get access to these medications, what is the cost, and which groups are being kind of left behind. So really quickly, we can go to the next slide. I can share why I think you might want to hear about this from me. I, in my everyday, work at a lifestyle change virtual care provider. So we've provided, I think at this point, 1 million patients have come through to get lifestyle change from us. And we've thought a lot about the treatment of obesity and what does GLP medication mean for a population that we care so much about. We also work a lot with payers and with employers that sponsor this medication. So we really want to be able to give them the best advice about how to approach this. What's interesting is we are not currently prescribing GLPs at my organization, and we can talk clinically why we've made that decision. But I do feel like I have a lot to say about what patients feel about these medications, what we're seeing in the real world in terms of side effects and access issues, and perhaps even more importantly, what role lifestyle programming means with these medications for patients. So let's get started on my first slide, which is I am so proud to say that this is something that those of us, I've worked in obesity for 20 years, have felt for a really long time, that obesity is a chronic disease. But I think if there's one good thing, of many good things, but one of the best things to come out of the addition of GLPs to the treatment available for obesity is that we really are now meaningfully talking about obesity as a chronic disease. And it's a chronic disease that requires long-term treatment. That could be with medication. It also could not be. What we've struggled with a lot in the obesity community is helping people understand, and those people are patients, our colleagues, the folks that authorize payment for treatment, that obesity truly is a chronic disease. The genetic, physiologic, and behavioral milieu in many cases is fixed for these patients. And so having long-term lifetime treatment available is important. However, that does not mean that that lifelong treatment necessarily needs to be medication. So now let's talk a little bit about medication. So next slide. So how do GLPs work? So GLPs, as many of you probably know, are agonists of the GLP receptor, and in that way activate several important parts of the body's metabolic milieu around regulating hunger and satiety. So the first way that GLPs work is by slowing digestion. Food remains in the stomach for longer, you have delayed gastric emptying, and as a result, many individuals feel fuller, faster, and for longer. Along with that, there is appetite suppression. This acts centrally in the brain via ghrelin and leptin and insulin, and people feel less hungry. Patients eat on average 500 calories less per day. So just to let you know, because we do a lot of food tracking in the organization that I work in, patients are eating as low as 800 calories a day sometimes on this medication. More common is maybe about 1,000 to 1,100, but this is a very highly calorie restrictive diet that ends up happening as a result of this medication. If you click, I believe we have a build here that's going to pop in. That's right. So coming soon is we're also going to get beyond just GLPs alone. And we saw this recently with the approval of tirzepatide as a new FDA approved treatment, where we're going to go more broadly into the incretin family. So we now have GIP and glucagon agonists, and pretty soon we'll also have GIPR that will come in as well. And so the complexity of the mechanism of action of these medications will increase as more agents come along. Next slide. So among all the FDA approved medications for obesity, for those of you that have been in obesity care, I call this my blast from the past slide, because this is a full accounting of all the different kinds of things we've seen and how they act in the body. It's important to know that we've had agents in the past that act locally in the GI tract. We've had agents that act centrally in the brain around appetite. And if you look for the red dot, you will notice that GLPs have action in a lot of different locations, whereas in the past, medications like an orlistat, for example, might have been acting only locally in the stomach. So GLPs are truly a systemic medication, and in that way have systemic impact, but also have systemic side effects. Next slide. As we think about semaglutide, which is our current most commonly used GLP for the indication of weight loss and was the first agent approved by the FDA for weight loss, how does it work? So it works by increasing satiety, lowering appetite, increasing insulin secretion, decreasing insulin resistance, decreasing gastric emptying, and some effect on the liver as well. Now, of course, everybody on this call likely knows that these medications were initially approved for treatment of type 2 diabetes. So many of the mechanism of action is geared toward lowering circulating blood glucose. And GLPs were actually discovered in 1987. The first drug, I'm going to mispronounce this probably, exenatide maybe, hit the market in 2005. And the first FDA-approved GLP with an indication of weight loss was in 2021. And so this is a big change in the treatment of obesity. And as a result, there's been a big surge in use. Now, even before semaglutide was approved for the FDA indication of obesity, there was off-label use that had been very common under the labeling for type 2 diabetes. And I think it was some of the anecdotal evidence of weight loss among the type 2 population that spurred the manufacturers to look at a new indication for obesity alone. Okay, and we go to the next slide. So let's talk about GIP and GLP-1 active medications. So tirzepatide adds a gastric inhibitory polypeptide mechanism of action. What's the additional add of the GIP to this medication? Well, we know that with each additional incretin agonist that's added to the medication, it seems that the amount of weight loss goes up. And that is likely due to a doubling down of the primary effects of the insulin and ghrelin and leptin effects. Now, with tirzepatide, it's also active on glucagon as well. And interestingly, if we go to the next slide, soon we will have retatrutide, which will add glucagon agonist, and it will be a triple agonist medication. This is not currently FDA approved, but just as going back to what I said initially, if I were thinking of what I would want to get out of this talk, I would want to know, okay, what's like coming? What do I need to know about? So tirzepatide is the next agent that I don't know. Maybe we'll see an oral version of semaglutide, but we'll definitely be seeing tirzepatide we've seen tirzepatide, retatrutide very soon here with its action with glucagon. Okay, so how do all these agents measure up against each other? If we go to the next slide, this is a graph from a Lancet review, not expecting you to look at this. The type is very small, but it just gives you a visual. On the right-hand side, we see this GLP incretin class of medications. On the left side, we see our traditional FDA-approved medications for obesity. So you can see that other than phentermine, and I don't know who is on this phone that actually prescribed phentermine for obesity and has that experience in the past. Obviously, the side effect profile didn't work out. But other than phentermine, we really haven't had a medication that had the level of impact on appetite even in the same ballpark as these GLP agonists. And so you can see on the right-hand side with the introduction of semaglutide, we're getting 14, 15, even 20% body weight loss at a year with these medications. And you can see on the right-hand side, tirzepatide is superior to semaglutide, but we're going to have a little bit more about that on the next slide. Good, next slide. So what about the GLP-1s? So the GLP-1s, as they rank up, we have a lot of different agents, semaglutide, tirzepatide, retatrutide, and then you can see on the left-hand side, we have a new oral medication that's currently in final trials. And you can see the range of weight loss that's possible with these medications. So as you remember back to the triple agonist of retatrutide, you can see that the weight loss associated with that medication is 24%. that is much, much higher than semaglutide. As a pediatrician and adolescent specialist who's treated a lot of patients with eating disorders, I have a high familiarity with what a calorie restriction diet means for an individual, what it means for their day-to-day and their side effects. And so I look at graphs like this myself, and I wonder how much weight loss over how much time is too fast, and are we going to get to a point where we have suppressed appetite, where the calories that are coming in just aren't enough for the body to function. But current state, the main goal of these agents in the pipeline is to drive up the weight loss as high as possible. If we go to the next slide, we can see how this compares with how these medications performed in the diabetes population. So if you look at semaglutide weight loss in the diabetes population, you can see that it's much lower than what we're seeing in the obese population. There's many, many reasons for this. It's harder to lose weight when you have type 2 diabetes. Also, the dosages that have been used in the past for these medications are sometimes different. And also the other medications that people are on at the same time may be weight promoting and counteract the effect of the appetite. But we're even seeing higher weight loss in the obese population for these medications than we saw in type 2. All right, next slide. So just to summarize, the evidence from the clinical trials of what you could prescribe right now if you wanted to. There are 3 agents available to you: liraglutide, semaglutide, and tirzepatide. And you can see that tirzepatide is superior on the weight loss, both in terms of the average % weight loss and then also the clinically significant bar. In the obesity community, we talk about 5% of a person's body weight as clinically significant. You can see that on all aspects, tirzepatide is superior. If rapid weight loss is your primary treatment goal, it is probably going to be the most effective. It is also the newest agent with FDA approval, so the coverage will be lagging for those medications as you're thinking about them in your patients. Next slide. So as we think about the pipeline coming up, there are about 50 medications now from phase 1 all the way to FDA approval. I have someone on my team whose job it is to keep a tab on this, and I have to tell you, it's a daily project to keep up to date. There is so much R&D happening within this world. Novo Nordisk and Lilly are the manufacturers that have invested the most R&D in this, with Pfizer, Amgen, and Zealand and AstraZeneca close behind. Many are in phase 2, moving into phase 3. We anticipate as soon as 2024, we'll start to see more of these medications getting approval. We've already seen that with tirzepatide earlier this year. And there's been major improvements in mechanism of action with lots of potential for combinations. And I put this comment in: more patents, more money. Again, just pointing out that the business opportunity here for pharma is enormous. So that is driving a tremendous amount of innovation in this area and a lot of investment. I believe, again, this is a little bit of a future forecasting as a physician who wants as many patients as possible to affordably access this medication, that with this amount of development in the pipeline, it would have to eventually impact pricing, because there's a lot of market here for pharma, but hopefully we will see that with all this competition, it will favorably impact access. And if anyone on this call has a prediction or an inside line on when that might happen, I think we would all love to know. Because access has become rapidly the hot topic with these medications due to the cost. Next slide. Okay, so the drug pipeline highlights, just to give you a sense of where the investment is on the type of impact of where things are, where the investment is happening. And this graph actually, let's just go to the next slide. I think the alignment got off, and I'll just speak to it. So most of the manufacturers are investing in GLP plus something. They are trying to differentiate themselves by picking a different agonists to make themselves more unique. GLP is the common thread with almost all of the agents that are in the pipeline. I would say GIP agonist as a close second, as an addition, is one of those. But after that, it's anyone's guess, adding glucagon, GIPR, all these other different types of mechanisms. To just bring it all together as a clinician, what do I want you to know about the drugs available and the pipeline? I think I would like you to know 3 things. The first is more additional mechanism of action leads to more weight loss. The second thing is there's a lot of competition and a lot of development, which will hopefully favorably impact price. And then 3, that the complications and side effects will be complex for you as a provider to understand. And we're going to talk about those more now, because as we get different mechanism of action and different types of agents, it will come with different types of side effect profiles. So the educational burden will only increase for providers at the bedside as they consider these medications, because with bespoke mechanism, the side effects will differ. With that said, since the commonality seems to be GLP-1 agonists with most of the medications, let's talk about the side effects of that mechanism of action. So first and foremost, in clinical trials, 73% of semaglutide patients report gastrointestinal side effects. Like I mentioned, we have thousands of patients going through our lifestyle change program currently, so we've really looked at this, and nausea, diarrhea, constipation, vomiting, and abdominal pain is prevalent in almost every single person that takes this medication in some way, shape, or form. As a treatment pearl, I would say that these side effects are much less if you approach a more gentle titration up. You will find a little bit of patient pressure on access, wanting to get that titration up to get that weight loss going as quickly as possible, given access and cost. But I would encourage you to stay strong and embrace a slower titration up to minimize the side effects. The side effects are tolerable to the patient until they achieve the weight loss. And then once they achieve their weight loss, it is the #1 reason they want to go off the medication. We'll talk about the risk of weight regain as part of that, that decision making piece. Okay, next slide. Okay, so the biggest side effect, as we all know from a medication, is no effect. And the worst type of no effect is to regain the weight with weight loss after you have had the treatment. This is, again, not new to the obesity community. As I mentioned, I've been in obesity care for 20 years, and the most feared complication of any treatment is weight regain, because typically the treatment has involved a tremendous investment of the patient historically in lifestyle change and pursuit of a surgery, and now in taking a medication with a high side effect load. To regain that weight is absolutely devastating to the patient, given their what they've put in to lose it. But our track record here is not great. Lifestyle change, people regain as high as 5 kilograms at 10 years, bariatric surgery, a very high rate of people being within 5% of their original weight loss at 4 to 5 years. And with GLP-1s, 2/3 of the weight loss, this is in the published studies from the manufacturer, 2/3 of the weight lost is regained in 1 year after discontinuing the medication. Now, my suspicion is that part of that is that, not suspicion, but my sense is that obesity specialists and the manufacturers are recommending that these are long-term treatments. I think that that makes a lot of sense for some patients, but I can tell you from the patient perspective, they want to go off of these medications once they've reached their treatment goal. The side effects, the lifestyle on these medications is not what patients want. And the vast majority are looking for an opportunity to titrate off once they've reached their treatment goal. So we have to have something to offer them when they go off the medication, just purely based on patient preference. But as I mentioned, there are patients who would benefit from being on the medication long term. Next slide. Okay, so why is weight maintenance so hard? It's interesting. I give this talk a lot about weight maintenance. If there was one area of GLPs that I would say is a passion of mine and also an expertise, it's becoming how do we, through lifestyle change and behavioral support, help people maintain the weight loss after they've gone off the medication. I do feel a little bit early to this topic because right now most of the chatter is around what are the agents, what are the treatment algorithms, How do we get access? And those are all really meaningful conversations to have. But I truly believe in the next 2 to 3 years, given what I'm seeing in the patient population regarding their preference, we are all going to be talking about how do we maintain the weight loss and what is the hormonal milieu that patients are left with once they go off these medications. So why is maintenance so hard? Well, this goes back to obesity as a chronic disease. Why is it so hard to lose weight in the first place? Why is it so hard to maintain? So first of all, we have our biology and genetics. There are, and I'm going to go over this in detail, there are significant adaptations in resting energy and body metabolism that happen with these medications that make you very prone to regain the weight. Secondly, the behavioral barriers that patients had prior to starting the medication are often fixed and still in existence after the medication. These are everything from social drivers of health to mental health barriers to educational barriers to access to care barriers to all those different kinds of things. And in addition, off the medication, there's a persistent need for this calorie reduction and significantly increased physical activity. So not only do these barriers still exist, but the need to address these barriers is increased in the weight maintenance phase. And then environmental barriers. Okay, if we go to the next slide. So now I'm going to perhaps offer to you, maybe force you to hear a good 5, if I'm lucky, probably 7 minutes on the post-GLP metabolism, which is a geeky topic of mine that I have gotten very, very interested in. And I personally think it's fascinating. I hope I will convince all of you today how fascinating it truly is. So when people are on GLP medications, as I mentioned, you have an increased satiety, decreased appetite, your metabolic rate slows, and you have a decrease in your total energy expenditure. This is not just due to the medication. So as an eating disorder physician, I can tell you that anyone eating a 1,000 calorie diet will have an adaptation to their basal metabolic rate that will cause a slowing over of the entire, body machine. This is part of rapid weight loss. This has nothing to do with GLPs. It's just about the weight loss that's associated with it. So when you go off the medication, you have this enormous mismatch. And this is the part that I think is so fascinating. Your satiety goes down, your appetite goes up, but the persistently low basal metabolic rate persists. And this has to do with 2 things: the rapidity with which you lost the weight and the reduction in your lean body mass. There's a ton of discussion about lean body mass and GLPs. The way I explain it to our patients and to the providers on my team is it's not like the GLP is zapping skeletal muscle. What's happening is people are losing so much weight so quickly that they're essentially wasting. And so their lean body mass, unless you add strength-based exercise while you're on the medication, which I would tell you absolutely recommend to your patients that they do so, you're going to get a reduction in the basal metabolic rate that persists once the medication is discontinued. So now you've upped hunger, lowered satiety, and you have a slower motor. This is a setup for weight regain. So if we go to the next slide, I'm going to walk you through what this means for patients. So just to remind you what resting energy expenditure is, body weight is regulated by negative feedback circuits that influence food intake. The body tries to maintain its weight. So when you lose a bunch of weight, your body is trying to get that weight back. It doesn't know that you are at an overweight set before. It just knows that it's lost weight. This means that weight loss is accompanied by persistent endocrine changes that increase appetite, decrease satiety. You're hungry, and what we tell our patients is it almost feels like the food is calling to you. And so you go into a hyperphagic kind of state. This resists more weight loss efforts and increases the difficulty of sustained weight loss. I would offer that this is actually why a lot of people reach a plateau with a lifestyle change-based weight loss regimen, is that you get to a point where your basal metabolic rate resets to a lower level, and you need to amp up your lifestyle change efforts to achieve the same amount of weight loss if you're still trying to move forward to your goal. So for each kilogram of lost weight, the calorie expenditure decreases. The REE decreases by about 20 to 30 kcals per day, whereas appetite increases by about 100 kcals per day above the baseline level, and that is the gap. And now I'm going to walk you through what that would mean for an average patient. Next slide. Oh, first, let's do really quickly, what does the literature show? So there's a great research study for people to know about, which is called the National Weight Control Registry. This is an amazing body of research that has looked at a cohort of individuals who have lost weight and what behaviors are they adopting that allow them to keep that weight off. And what we've learned from the National Weight Control Registry, and this is something you can incorporate into your practice, that people who are successfully able to maintain that weight loss, 78% are still eating breakfast every day. In other words, they are not skipping meals. 75% are weighing themselves in at least once a week, so they're monitoring their weight. And then finally, 90% exercise on average 1 hour per day. That is sobering. So just absorb that last bullet as a clinician, informing a patient who may have never engaged in an exercise regimen really for years due to their status with their weight. Helping them understand the importance of this exercise is a bit sobering, but it's absolutely paramount. Okay, so now we're going to go through some fun bits on an average patient. So next slide. Okay, skip this one and go to the next one because we already did that one and we're still on time. Okay, so let's imagine that we have a sedentary, obese 48-year-old woman with a BMI of 31. She starts with a 2,000 cal per day diet. She has a non-exercise activity thermogenesis of about 600 calories per day. Her thermal effective meals, or her TEF, is about 200 kcals per day, and her resting energy expenditure is about 1,200. So she is in energy balance. She is maintaining her BMI of 31, and this is what her metabolism looks like. All right, next slide. Now let's say that this individual goes on a GLP-1. Now she's eating 1,200 calories a day. Maybe she's added a little bit of exercise. She's feeling a little bit motivated around her weight loss, has added, about 200 calorie per day burn of exercise. However, the medication has lowered her NEAT and it has lowered her resting energy expenditure due to all the factors that I just explained. She still has a calorie deficit of about 600 calories a day, and she's going to lose weight. And that is how we see weight loss with GLP-1s. Next slide. Now, let's say that she gets down to her goal BMI of 23. And in conversation with her provider, she asked, can I go off the medication? I'm now at my goal weight. I'd like to maintain my weight now and go off the GLP. So the GLP-1 is removed. The NEAT stays at 400. The thermal effect of meals stays at 200, and the REE remains at 1,000. But what does change? Her hunger and satiety cues. So now she is hungry for 2,000 calories a day and finds herself taking in 2,000 calories of energy, but only burning 1,800. So she now has a positive calorie deficit of 200. And this explains why there is weight regain when people discontinue GLPs. If we go to the next slide, we can talk about why exercise is so important. Some of you might be sitting here wondering, well, hey, Carolyn, why does the REE stay at 1,000? Is there a point at which the REE bounces back where your basal metabolic rate will go back to that original 1,200 that she had when she had a BMI of 31? Here is the sobering and interesting detail with a fun fact. So one of the best research studies in this was following contestants on The Biggest Loser, where they did a full metabolic cart and measured what happens to the metabolic rate in people who have lost a significant amount of weight over time. And what they found, and what has been confirmed in other studies, is that this slowing of the metabolic rate persists for years and may never come back. So there is a permanent reduction in the basal metabolic rate after a weight loss journey that persists, that can only be counteracted by either building lean body mass, which is of course healthy and amazing for individuals, embracing an exercise routine, which is of course healthful as well, and committing to eating a modest amount of calorie intake. So if we go to the next slide, this is the rub for patients. Your patient that had the obesity history that took the GLP on the right compared to your patient on the left, both of whom have a BMI of 23, would need to have a very different lifestyle approach due to the historical presence of obesity for that individual. And the person on the right would need to understand their metabolism, embrace that reality. And if they wanted to pursue a lifestyle, which I think is healthy, of eating adequate nutrition, the recommended amount of nutrition for an adult woman in a day, they would need to commit and incorporate a regular amount of exercise. Now, this is not to say that the person on the left is not exercising as well. It's merely to illustrate this point, that this is an extremely important conversation that you need to have with your patients when they're going off of a GLP, to get them ready for this step and help them understand their metabolism and what they'll be fighting against in this post-medication period, so that they don't have that undesirable experience of regaining the weight when they go off. I will take one moment out to just say a little bit about pediatrics and adolescents. This concept is very different in the adolescent population. First of all, they have an evolving metabolism. Their metabolism in many cases is increasing to support their growth and their puberty. And so it would be a very different picture in an adolescent patient that you had chosen to put on a GLP. And we, I think in the Q&A, are going to answer some questions about what types of adolescents and under what circumstances is it a good idea to look to this medication. So we'll just leave that for the Q&A. Next slide. Okay, so the promise versus the reality. So the promise of these medications is that people will lose weight, which is the bottom graph. The reality that I'm seeing in my clinical practice, in the environment in which I work, is that the reality is that people are regaining the weight. On the top, you'll see lifestyle change. So that's why this promise is so attractive. I don't think you would find someone who has been more passionate about lifestyle change for obesity than me. I've dedicated my whole career to behavior change, whether it's in children or adults, using virtual versus community. I have really embraced lifestyle change so wholeheartedly. And I look at this curve and I think, wow, these medications are an amazing new tool. But then I look at the right-hand side and I think, well, what's the reality here? And what are we really going to get from the investment that we're putting in? And how can we combine both to make the treatment even more powerful? So combining the lifestyle change with the GLPs. So I'm going to finish each section by sharing what I hope you take away. So what I hope you take away from the side effect and risk section of this talk is, first, the side effects are real. The patients don't like them. And because of the side effects, they want to go off the medication. If you take a patient off these medications, and I say if, because I think there are some patients for which it makes a lot of sense to keep them on the medication in perpetuity, you have to not do the usual thing we do as providers, which is to congratulate the person on their weight loss and unplug. This is really a lean in moment for you to have a serious conversation with your patient about behavior change and lifestyle, and make that part of your readiness assessment to go off the medication. Is this individual really ready to commit to the type of lifestyle changes that are required to maintain this weight loss, or are they at risk for weight regain post medication that would just be devastating for everybody who's made such a commitment to the medicine. Okay, so now we're going to talk about treatment barriers, which is in some ways the hottest topic in this area. Okay, so next slide. So the global weight management market size is valued at about $130 billion. This is probably, as providers, our biggest challenge for getting broad-based access to this medication vis-a-vis a price reduction. There is so much pie here for the manufacturers that they will slice and dice this pie for as long as possible at a price that makes sense for what they believe the market can bear to pay. So because of the high prevalence of this disease and the huge amount of market that's available, there will be a lot of room for a lot of innovation before we see a change in price. And that is a constraint. If we go to the next slide. So the reality of where we are right now is medical costs for patients who are on GLPs increase about $7,000 in the year in which they're covered. So, and a third of patients who are prescribed GLPs are only a third are still taking it at a year. So when we talk about treatment barriers that you see at the bedside, who is paying for these medications? So if you chase the dollar back to where it's coming from, it is the dollar for the medication is coming from 4 places. 1, the person's employer through employer-sponsored health insurance. 2, through the health insurance plan directly. 3, the government, or 4, from the personal pocketbook of your patient. Those are really the only ways that the medication gets paid for. The personal pocketbook is a huge disparity issue where only the wealthy will have access. The government to date, other than GLPs for type 2, has opted out of coverage. Health plans, due to their fully insured population, have also by and large opted out. Some employers are leaning in on coverage, and you may have had experiences with some of your patients where it is covered. But current state, the most likely way you will be able to get access for your patient to this medication is if their employer has happened to agree to cover the medication, and then you will pursue a prior authorization process, or if your patient is able to pay personally. Hopefully all of you are aware of savings cards and discount cards and things like that that are available, savings programs through the manufacturers, that if you aren't aware, you should educate yourself. That can reduce the cost a lot for your self-pay patients. When you write this prescription for obesity, you also need to understand that you are also signing yourself up for a prior authorization process that hopefully will not be too painful, but will definitely be present. And probably more than half the time, depending on the BMI of your patient, it will result in disappointing news that it is not covered. I do believe that as more agents come in, the price will start to drop. We've seen a little bit of that with tirzepatide. The price is a slight bit lower than we saw with semaglutide. So I think that with every new agent, we will see a lowering of price, and that will increase access. I work a lot with employers who cover benefits, and they want to cover this medication. They want it for their employees. They believe that it is amazing treatment, but it is currently unaffordable at the price that it is. It is not something that employers have the funds for to cover. So we find ourselves in a difficult spot. If we go to the next slide. There are some companies out there where patients can get these medications virtually. I am not, I want to be very clear, recommending this. I'm actually more putting this slide up as a cautionary warning to all of you, because your patients are as likely to ask you about this medication as they are to go to a virtual care provider. I think it's very important for you to know that these virtual care providers exist. This is currently a big way that people are getting off-label use of these medications, a big way that people are accessing vanity use of the medication. And it is very possible for patients to access GLP-1s on a self-pay basis through a virtual care provider. So I would encourage you, if you have a patient who has rapid weight loss, to inquire, how have you done it? How have you pursued that? I don't think that virtual prescribing of GLPs is a good route for patients through a bespoke company. And the reason for that is much of what I've already described. All of the complexity of the titration algorithm, the side effects, the monitoring that's required with these medications. I feel very strongly that these medications should be prescribed either in a specialty obesity environment, through the medical home, or through some specialist within the medical home who's able to monitor, and where that record, that longitudinal record, is available to the rest of their care team. I think that one-off prescribing is complex. It's made better if you have a dialogue with your patient and you know that they're on it. This is part of the reason that my institution is not currently prescribing GLPs, because we believe in the medical home. Okay, next slide. Okay, so the only thing I'll highlight on here is that 22% of employers are currently covering GLPs to some extent. So that just gives you a statistic to go behind the access piece. We go to the next slide. Generics. So this is my crystal ball slide. When will the price drop and when we will have generics? So for those of you that are savvy, you may know that part of FDA approval for a new indication for these medications resets the clock on the patent. So the manufacturers have access for more time before the generics will come in. Now, generics, there will likely be lawsuits and other actions to try to get generic agents. There's compounding happening. There's 7 patent litigation cases that were started as long ago as 2021 to sue for generic access. The earliest date of generic conversion of semaglutide, just based on the patent alone, is December 5th, 2031. So I would look for access being improved more through price than generic availability, but there's a lot of drugs in the pipeline. This is a highly prevalent condition. It's possible that we could see some action around generics, but I think it's going to be some time. Next slide. Okay, so now as we enter the Q&A, I just wanted to thank you all for listening to this. Hopefully I've convinced you that you need to think a lot about lifestyle change as an adjunct to prescriptions for GLPs. And now I think Kim's going to ask us some questions from you.
Thank you so much, Carolyn. That was super informative. And we have so many robust questions this time, which I know we won't get to, but we're going to do our best. So you and I had talked about before about the issue of equity and disparities. Clearly they're there. Is there anything else you want to add aside from that, those sort of futuristic predictions about when it's going to happen?
A couple things. So as you think about those four entities that cover the medication, government coverage, specifically Medicaid, is actually, in my mind, one of the routes of getting the price down. So there's this special component of legislation under Medicare, which allows the director of Medicare to negotiate prices directly with pharmaceuticals. This was part of some recent legislation that was passed in Congress. So were Medicare to want to extend themselves in that way, we could see some improvements in price as a result of that, and that would increase access. But the Medicaid population is wholly not able to access this medication currently, except unless they have a type 2 diabetes. So completely cut out based on income. Regarding racial and ethnic disparities, that has a lot to do with the systemic racism within healthcare and accessing care. The friction that has been introduced in the prior authorization process, the amount of health literacy and advocacy that you have to get your medication covered. I think anyone from a race underrepresented group, specifically around race and ethnicity, is going to have additional barriers to access this medication due to the prior authorization process. So these barriers definitely are present and super sad. Not to mention the fact that the population itself, the obese population, has a disparity around obesity. So it's a big piece of this. Yeah.
Yeah. So for those of us in and around the CMA, this is a big advocacy issue and an equity issue that we can all get behind. Carolyn, as you're an expert in this area, and everyone knows I always talk about the pediatric population because I'm a pediatrician myself. Can you talk about the use in adolescents and what you'd recommend?
Yeah, absolutely. So depending on the agent, some are approved as low as age 12. I will say clinically for me, obviously it's a balance of risk versus benefits. As an obesity provider, I want to fully disclose I'm not currently practicing in the weight management clinics in which I used to work very frequently. But from what I know, which is a lot about these medications, I would look to this medication in particular patient populations. So definitely in a post-pubertal population, I would want to look at, for example, a population that's on potentially weight promoting medications like steroids or psychotropic medications that promote a lot of weight gain. I think these medications can be helpful in that population. I think these medications can be very helpful in patients who have meaningfully tried to engage in lifestyle and in concert with the family, you feel like this could be a really open a lot of doors for them. The eating disorder population is a very complex topic. There are obese adolescents that have binge eating disorder. There are patients that vacillate between being undernourished and overnourished. I would say that part of prescribing this medication in the adolescent population, I really think that We're so blessed in California to have so many centers of excellence. I would recommend that if you're considering this medication, to do it in concert with your local pediatric weight management clinic or with an eating disorder program to really make sure that the proper screening for the disordered eating behavior has been done, that you have exhausted lifestyle change. Prescribing it right out of primary care without some of these other supports, I would just want you to take a breath before you did that. Yeah.
Super helpful. As you've alluded, it's very early in the life of these medications. So what, if anything, do we know about long-term use and potential implications of that?
Yeah, so we know a lot about long-term use through in the type 2 population, right? So in patients with type 2 diabetes, we know that these are safe medications. They're very effective for diabetes in the long term. We do not have long-term data in the obese population, except for obese individuals who happen to have type 2 diabetes, but their physiology is so different. So we really don't know. We do have more and more studies coming out on discontinuation and weight regain. That's the area that we're most about. Something that we're committing to, and we just made an announcement about this a couple weeks ago, is we're initiating a longitudinal cohort study with folks to understand the natural course on a GLP, who discontinues, why do they discontinue, what does their weight regain look like, if people continue the medication, what is their side effect profile. That real world evidence research is so important. And I would imagine there would have to be people on this call that have access to either large EHR data sets. This is not research that I think the payers or pharma will, or manufacturers will engage in. I think that this is really for us as the provider community to produce that real world data. So if you are an individual that's in a large center or has access to large amounts of data sets, and you are a researcher or collaborate with them, I would consider taking on some of this work, because it will be up to us to produce it. Yeah.
Speaking of research that I'm not sure if has been done, but we may want to ask participants on this call to engage in, has a cost analysis of the implications of these very expensive medications been done that looks at the short and then long-term overall healthcare costs?
I love this question. So there's a group called ICER, which hopefully at least some of you are aware of, that looks at the ROI of all different kinds of medical care, often pharma-related care, medication, therapeutics, and they. What I'll say is, in their report, they propose a price at which these medications would break even. That is far below the current price that these medications are offered at. So I would take a look at that ICER report. We can certainly make it available to everybody. I think that would be, I know the CMA and many of you are strong advocates in your communities and even nationally on healthcare. I think calling attention to the gap between the cost at which this does make economic sense and the current cost that it's offered at would be a great way to frame a meaningful conversation about price.
Mm-hmm. That is super helpful. And I'll just comment that to everyone in the audience, if you haven't noticed, that the handout from this virtual grand rounds with all the slides is already available. You can download it now. But when we send out our email this evening, we actually can get that link, Dr. Jasek, and hopefully send that out as well.
And I was planning to refresh that, because obviously there are new agents and new pricing. There is some literature as well on now that we know more about the weight regain, that takes a dent out of the ROI savings of the medication. So a lot of the modeling, this is a hot topic for me, is ROI depends on the weight regain trajectory that eats into a tremendous amount of the savings. So no pun intended, sorry.
And you may have said this, but for those of us who are physicians and not business people, ROI is return on investment.
Right. Yeah.
You may have said that, but just making sure that we are all on the same page.
Small giggle to me that I'm a business person on that call. I would have predicted a switch.
So that another question that a lot of people had, and I think is fair, and I think you probably have views on, is how do you think it's best to titrate up these medications? And then as a second question, what is there a preferred tapering protocol when you're stopping?
Not to be cheesy, but I would say slow and steady wins the race here. I think that there's a lot of pressure from patients to titrate up quickly because of cost. And I think that the slower you can titrate, the better because of the side effects. I will also say, interestingly, this is a clinical pearl, is the bulk of the weight loss happens in the first 6 months. I honestly think a lot of the weight loss is due to the side effects that people are feeling. They don't want to eat because they have GERD and they have stomach aches and they have all these other side effects. I think that in addition to the natural effects of the satiety on the hormones and all of that. So I think slower titration, but I would also say going off the medication, there just isn't enough discussion about what a post-medication titration regimen looks like. There's also some people are wondering about adjunctive medication post discontinuation to maintain some level of appetite suppression. I've heard people talking about metformin. I'm not recommending that. I haven't seen that data. I've heard people talking about other kinds of medications to add post GLP to try to manage that hyperphagia kind of piece. But I think what you can do right now is just as you're seeing someone getting closer to their treatment goal, I would say this is a whole visit to meet with the person and say, let's talk about readiness for discontinuation. Do you want to discontinue or not? This is a patient-centered conversation. Okay, you want to discontinue. What does that look like for you? How are you going to up your exercise? How are you going to focus on your nutrition? Let's titrate you slowly. Let's meet halfway during the middle of it to make sure it's working. Again, it's a time to lean in and really approach it carefully to just maintain the progress that has been made.
Great. And sort of a related question is, if you're going to resume this therapy after a break in the therapy, would you titrate up slowly again, or is it okay to resume at the latest dose that was tolerated?
This is really, the answer is nobody knows the answer to this question. So we see this scenario constantly where people have been on the medicine, either they stop it or there was a supply chain issue, and now it's been 2 weeks, 3 weeks, 4 weeks. Okay, if it's been 4 weeks, you probably need to go back a couple titration levels. If it's been 2 weeks, I don't know. I mean, I don't know what to tell people. I think it's always safer to go back a step. The problem is the supply chain issues go higher, the level back you go. You're going to have lower supply chain challenges the higher up your doses. So I think what I would do if I were you is I would prescribe in advance and help people sort of have that next, don't up the titration the exact week you need them to fulfill the prescription because the supply chain issues. Start the next dose like a couple weeks ahead so that that person can have it in hand. That would be, I would say, the most important thing, and have that person have an ongoing conversation with their pharmacist. The pharmacists don't want this either. So if they're talking to their pharmacist about what are you seeing, which, I mean, they know what doses they have and what they have to do. But again, another example of the amount of health literacy you need to be on these medications, honestly. Yeah.
Amazing. Okay, so to change the subject a little bit, you alluded to off-label prescribing and sort of vanity prescribing. Do we have any sense of the volume of that, of how big that practice is?
Well, we hear about it a lot on TV, right? Like people talk about Real Housewives, this and that, and whatever's happening. We have a real challenge with off-label use in the following way. First of all, there are people who are weight restored, right? Who have lost their weight and they're at their I don't know if that's the right term. Sorry, that's more of an eating disorder term, but like at their goal weight, right? Are they off-label use at that point? Like, what if they go off for 6 months and they gain just 10 more pounds and they're like, shoot, I really need to be back on that GLP. Is that now off-label or is that on-label because they used to be obese? This is all getting very confusing as people lose more weight. But let's do what you're really asking about, which is someone who's starting, who is not FDA eligible for the medication based on BMI, but wants the medication for that weight loss. That is something that is very concerning to me. There are so many supply chain issues right now for this medication, and especially many of those off-label uses are taking the semaglutide branded version that's meant for diabetes and is covered for diabetes patients and taking it away from those patients. So off-label use is a huge concern of mine. Compounding is a safety issue. Vanity use is an issue. So I would say if you have a patient who has lost a rapid amount of weight and they are not obese or overweight and you're in California, I would just please ask that patient, how have you done it? And if they've done it with GLP, take a moment of patient advocacy to really have a conversation with them about what their behavior is doing for the supply chain. That's my personal bias, but it's just, we see it. I mean, there's so many supply chain issues with patients right now that want this medication and can't get it.
Well, thank you. It's a cautionary note that we end on, and I think that's fair in this topic that's very new. And also, I love that you ended on an advocacy point, because that's what we do at CMA. I wish we had more time for questions, but I really want to thank you for presenting this content and thank everyone listening in for taking the time to learn about this. Just a reminder, you'll get that survey at 5 p.m. today, and we'll send, if you fill it out, we'll send you your CME certificates within a week. And we'll send with you instructions on how to access the recording of this webinar. As usually, I think it's really valuable material, so please share with colleagues and friends. And just to note that we will be breaking from our usual second Tuesday schedule in April. So it's going to be on Tuesday, April 16th, and we're discussing a really interesting discussion about Black health in California and how to move toward equity. And CMA has lots of other great events coming up. In May, there's a Health IT Summit, which Dr. Jacek, you may want to attend. There's a Health Equity Leadership Summit and a Medical Group Advocacy Symposium coming up. So you can find more about that at cmadocs.org/events.
Thank you.
Thank you, everyone. And thank you, Dr. Jacek. We'll see you next time.